Great colleagues, we are at the top of the hour. Good afternoon, good morning, good evening, depending on where you're joining us from. And a very welcome to our LabCoP ECHO session for today. My name is Francis Ochena, Project Manager with ASLM. Our ground rules continue to hold, and we'll have this session running for 1 hour. We'll take a shared presentation and then get into the questions and discussions. We have language interpretation services. Please keep to either English, French, or Portuguese, depending on the language of your choice. Our session slides and recording will be shared as soon as they become available. Today, we're looking at some facets of sustainable programming in the face of a rapidly changing funding environment. Allow me note that studies that track past and projected health spending continue to show that with individual country level economic growth, such countries tend to spend relatively more on health per capita. But with that also comes the decreasing funding from development assistance, call it external funding. And also this adds to the desire, therefore, on a rolling basis for countries not only to develop comprehensive estimates of their health spending, but as a key input into their policy and planning, but they should also determine sustainable sources that this funding, the estimates that they are making, will be coming from. And those sustainable sources can be local funding sources, but also external funding sources. Again, allow me note that besides determining in a very comprehensive way how much we require in terms of funding for our health infrastructure and service delivery, there should also be a corresponding sustainable program development. The programs that we develop, be they preventive care and treatment programs, or the lab network for that matter, or the other services that support the delivery, those programs should also be crafted with sustainability in mind as one of the key principles really in developing any program. And in today's session, therefore, we will be sharing Malawi's a very structured response from Malawi, given the recent development in the funding environment. And this will be very specific to the recent development in the funding environment, but it will also extend to what they are doing going forward to ensure that their health programming is generally sustainable. And to take us through this, we have two presenters. Our first presenter is going to be Stanley Ngoma, and Stanley is the Care and Treatment Program Officer with the Directorate of HIV, STI, and Viral Hepatitis with the Ministry of Health in Malawi. And the second presenter that will then take it on after Stanley is Chifundo Iwa, and Chifundo is an Assistant Director with the Health Technical Support Services of the Ministry of Health in Malawi. And so colleagues, join me in welcoming Stanley to take the first facet of this presentation, and then Stanley will hand it over to Chifundo. Stanley, over to you.
Thank you, Francis, for that introduction, and thank you everyone for having me, Stanley, and Chifundo, plus the Malawi team to share our presentation. It's a great honor that we can also speak on this platform to share our experiences in terms of response that we've had in regards to the recent development with the funding shrinking and abrupt cutoff in regards to implementation of HIV services. So there are two presenters from here. I'll start, and then my colleagues, Chifundo, will take it up from where I'll stop in the same slide. Right, so just taking you through the background as the introduction. So our country, we are at 20 million in terms of the general population that we have. And in this population, we've actually managed to establish around 861 health facilities that are providing HIV, specifically ART services in the country. And of these, since the start of the program, we've been gradually having support from the implementing partners that accounts to 50% in these health facilities where ART services are actually being offered. And the 50% takes a huge chunk of the recipients of care that we are saving, because in total we are at 900,000, and where I've got 50%, we've got 90% that are being saved by these facilities that are supported by the IP implementing partners and PEPFAR agencies. 10% only is those that are being supported just by the government, where we don't have any support. So this is just a profile in terms of where we are in terms of the population that's being saved in those health facilities. And as a country, we basically also conduct what we call the goals models, just to see how much support might be there in terms of the external support, because from the previous slide I mentioned of the IP support to this HIV program, but we've been looking at continued implementation of services where there's no partner support, and we've been looking at this now with 10% reduction in terms of the funding that gets to each of the intervention. So we conduct what we call the goal models. So as Minister of Health through M1E colleagues, we work together with the Avenue Health to conduct such modeling to see which of the HIV intervention across the cascade, so from prevention to treatment and care, is having much more impact in terms of abating the new HIV infections. And we've seen that ART itself is actually taking a leading role, constituting to around 63.1% in terms of abating the new HIV infections, and then condom use, and also looking at the future generation, where we talk about the PMTCT for the children that are born to HIV positive women, that they should be free also from the HIV. So providing the comprehensive HIV interventions to make sure that they have a healthy outcome in terms of the infections. So these are the interventions basically that we've done around the goals modeling, and we see them to have much more impact. And in terms of implementation, also looking at who supports to such service implementations, the issues of human resource has played a greater role in terms of prioritization, and also to have all this data, to have all this information, we've used different data sources, including the quarterly program data that we collect in all the 861 facilities that I mentioned earlier on, as well as data sources from the UNAIDS and also the FIA and different other surveys that we've done in countries. So this has led us to have such percentage representation in terms of case aversion, the new infections that we might have over time. So this is how we've done, and we did this to make sure we do the program prioritization. So the interventions should be prioritized considering the trajectory that would have. Getting to 2030, that was our goal, that if we don't have any partner support, where do we get to? So we've been looking at the trend with the annual funding reduction. So from 2023, we are seeing there on the graph on the left side bar, 157 million funding support to all these interventions. You are seeing on the far right. There we've listed economic empowerment, VMMC, key population, and the rest on the list. And if we are to implement all this, we'll be having these funding cuts. And will it be sustainable as a country to continue implementing all these? And this is the reason we've been doing the goals modeling to see those that have got much more impact in terms of abating the new cases. So we saw that it would be shrinking and would be only at maybe 92 million. This is with the current previous status quo. It was before the coming in of this stop order with funding support from the USG. Already it was getting down. And for that reason, as a country, we're eyeing to reduce most or downsize most of the interventions like 2 years before the actual target of 2030, making sure now we reduce some of those interventions that their impact it's minimal compared to the other. But with the bang of surprise, we saw it coming 2025, it has happened. And for that reason, we're actually now optimizing which services should continue with the funding that is available in country. And this is across the HIV cascade, from prevention to care and treatment, and also onward monitoring of our recipients of care that are receiving treatment in various facilities that we have in country. So for that reason, it prompted the ministry actually to downsize in terms of which interventions can continue running with what is available. And this is the decisions that have been made. It's been based on country context, may not apply to every country, but also other countries can also make their own decisions depending on what is available, because the fundings sources might also differ between different countries. So as Malawi, this is what we decided to actually downsize which interventions should continue and which interventions should be deprioritized. And with the same trajectory that we've been making, already we had a goal that come 2030, we'll be able to reduce the new infections by less than 5,807 with the status quo before the stop work order, or with the cutoff of funding from the USG. Still more, if we look at these three graphs, would not have met this target in terms of new infections that have been reduced. But instead, then, with this that has just come in as an abrupt decision that's been made, it's impacting us. There's a high risk that even we'll have infections rebounding, so getting a high rise of new infections. Those that we had actually projected would reduce by this already would not have reduced. And now with the funding cuts, it means it poses a high risk that infections will rise again. And once we have a rise in terms of the infections, we had also estimated, like in the same status quo, reducing the deaths by 3,691 in 2030. With this funding cuts, it means would also expect to have increase in terms of the number of deaths of the recipients of care that we actually serving in various facilities. So it has had a very huge impact in terms of the service implementation. That's aversion of new cases, as well as the increase in the number of deaths. This is expected with these funding cuts. So when we saw this communication about the stop work order from the PEPFAR government, as a country, we had to start making consultations. So on 20th January, this is when we got about this aid freeze to the countries, including Malawi. That was on 24th, and then on 30th January, we quickly sat together as a ministry to come up with a contingency planning meeting. This now resonates well to what I had mentioned, that where there's no funding, and we're looking into 2030, but now it has happened in 2025. What next? What should we do? So these consultative meetings had started, and with everyone that matters, including the recipient of care and the leadership of the ministry, and also the service delivery points where there's also that leadership. And to be followed up like weekly, not just having a once-off meeting, but weekly follow-up meetings to see how much progress we are actually making. So on 1st February, that's when we got the release of the US limited waiver. They can continue supporting us with life-saving interventions and HIV provision. And then as we continued to meet as Minister of Health, we came up with a guidance, which is the first edition of our HIV circular that was circulated around all the service delivery points in the Ministry of Health facilities. And in February, we continued to have some engagements with the donors because we got the communication that now they can start coming back to the facilities after the stop order from the lease that was actually provided on which was limited, to say, okay, which services now or what plan do you have now as you're coming back? So with the donors, we started all these communications, discussions, and then the individual IPs supporting different facilities to share the work plan as they come back, and also share our own, and then to see where they align, and continued engagement meetings that have been happening. All this was to make sure the services that we've had that got affected can resume, including the HIV prevention, testing, care and treatment, the viral load and DID sample collection, sample and waste transportation, distribution of HIV supplies, HIV viral load testing, HIV information management systems that anchors our data systems, the laboratory information management systems. These were the ones that were heavily impacted negatively. So as these partners were getting back, but also from the plan that we had actually developed as a ministry, where should they align? So as you go back, they get aligned to what the decision the ministry has actually taken. So in terms of the engagements, we had the top leadership in the ministry that was leading us through these discussions involving the interdepartmental teams, the recipients of care. On the same part of it, the National AIDS Commission that provides national response to HIV, the leadership in the districts, and also regulatory bodies, because there were some considerations in terms of the task shifting for some of the services in terms of implementation. So we've got Medical Council, the NSS Council, as well as the pharmacy regulatory bodies, they were part of it. So the discussions were centering around the HIV supply chain systems, the human resource, both the MOH as well as those that were seconded, the lab information system, our data component, the sample transportation, the HIV prevention and treatment care, and the rest of those that we had actually prioritized. So what we did as a response to this, as a ministry, we had to make a quick deployment of trained MOH to take over the positions where the IPs had actually left. And in the same discussions, we had actually issued the communication and the guidance that was provided that we need to optimize the 6-month restricting and dispensation to reduce the clinic visits and ease the burden of health facilities as we provide the services, the stock redistribution in the facilities, we avert the stockouts and also expiries that were slow moving on the shelf of these items. And the task shifting that I mentioned, that's why probably we had actually included the regulatory bodies that as we do this, they should also be recognized that some services that were meant for professionals can also be task shifted to these lay carriers. The private sectors are leveraging more so that some of the ART patients that from the huge volume facilities can also be located or transitioned to such private facilities in support of anchoring the cohorts that we have. Expansion of the community health workers for patient flow, and also making sure we bring back those that have been lost to care or lost follow-up, and they should be back in the facilities. And then our data basically gets corrected every quarter with support from the USG. With the cutoff budgetary support, we had to actually make some adjustments that it should be corrected like every like twice a year. So moving from quarterly to twice a year, because also taking a huge chunk of money to have these activities conducted. On the same way, we also had to categorize in terms of which services would continue normally and those that would actually be on a pause. So we had to prioritize and deprioritize some of the services. So with testing, this cornerstone on an entry point to HIV service provision, we said, I think testing should be prioritized to the antenatal women and also inpatients, those that are admitted in the wards, and also those that are having sexually transmitted infections. With testing, services should continue and at all site level delivery point. Mostly these are facility based. And the other thing was on the provision of prophylaxis, nevirapine prophylaxis, in a way of trying to make sure we protect the future generation in a program of mother-to-child transmission of HIV. As already we've got a goal, we talk about the elimination of mother-to-child transmission. We can't do without such prophylactic treatment regimens that we need to provide to these women, that they should take at specific milestone. The testing milestone should still stand for those who are exposed to HIV from their mothers. On STIs, trying to integrate the services into the general OPD so that they get screened and also managed right away in there because of the support that we had, considering the human resource that is available. We just integrate these services. Messaging on prevention and condom use through the routine health talks in the facilities as one of the preventive package. I think you might have also seen in terms of the impact that it has from the pie chart that I also mentioned earlier on. In terms of those that were actually deprioritized or modified services, so we had actually to stop immediately facilities dispensing what we call the emergency refills. So this has been featured in our HIV treatment guideline that if a patient moves between places within the country, and if they've forgotten their tablets, they actually visit the nearest facility where they are and present with the documentation to make sure they are really on treatment, and so they can be offered an emergency refill so that they still stay on treatment up until they return to their original registration site on the scheduled day, so they can have their refill, or they continue with their medications that they've left back home. We've stopped this one as a priority. It's no longer a priority on our list, and also the discontinuation of the oral and injectable PrEP. This one, it's not on a priority, but it's only happening in only those that have actually been initiated only. So we're not initiating more on this. And also discontinuation of the routine viral load testing, considering that the sample transportation and also sample collectors in the facilities, mostly of them, they were heavily being supported by PEPFAR through the R4H as an IP to this sample transportation. So we only consider those that are having the samples under targeted viral load testing. So we make a decision in terms of the treatment regimen change. In terms of the high viral load testing progress, from here, I will hand over to my colleague Chifundo that will finalize the rest of the slides. Over to you, Chifundo.
Thank you so much, Francis. Stanley, thank you. On HIV viral load testing, in Malawi, we have got 14 molecular testing labs. And I am proud to say that half of our molecular labs are accredited. And of the 14, we have got one that is supported, that is an IP molecular lab, that is PIH. And we have got 3 DREAM molecular labs under CHAM. This is Christian Health Association of Malawi. But the rest of the 10 facilities are Malawi government facilities. And also we have got gene expert platforms in sites that provide integrated testing for TB, EID, and viral load. We have got at least 80 pieces of gene expert machines that are integrated out of the 250 platforms that we have. We also have got 25 sites that provide EID services using MPIMA devices. In a normal setup, HIV testing viral load, like for example, in 2024, HIV viral load annually, we would test at least 8,875 viral load samples. That is what we tested in 2024. And monthly, we would test 70 to 80,000 tests per month. This one is a reflection of at least 80% of our annual goal of samples that are supposed to be tested. However, we also have got the ones that I just mentioned. These ones are the routine samples. But for the targeted samples that are tested on POC machines, normally we would test 18,000 annually on our POC devices. And monthly we'll test at least 1.5 thousand tests. I just want you to remember this slide because it will reflect much to say that how much a drop this will be if we are only prioritizing targeted tests, targeted viral load tests, as per the decision that we were forced to make. So this number is a representative of only 2% of all the samples that we test. Before the IP withdrawal, viral load samples that were received in the facilities, as per the data of 2024 November, we received in a week, we received 17,000 samples, 17,900 samples. And after the IP withdrawal, with no sample transportation in place, we were able to receive 8,000 samples. This is a drastic drop of at least half of the samples that would normally receive in the facilities. And another area that was heavily impacted was the testing. Before the IP withdrawal, in a week, Malawi will test 19,000 samples, 19,600 samples. And after the IP withdrawal, because of the withdrawal of data clicks, which were almost 90% of our data clicks were under IP, we were able to only test less than half of those samples, because now we were using laboratory technologists, laboratory technicians to be entering the samples in the LIMS. So that means they are quite slow because they are just adapting to this. Samples were available, but we were slow to enter them in LIMS.
Right, so I will take up the next slide. So it's looking at the progress in terms of implementation following the emergency response. So once we did this, now with staff redeployment, like we did, we had to support them with the clinical mentorship on the site for service delivery, making sure they adhere actually to the treatment protocols and also the policies that we have regards to HIV program implementation. And we also had to make sure MOH at every facility takes a reading law, because this one, the lessons that we got in here have been, we've learned them in a very bitter way. So we have to make sure the leading law stands at every facility, regardless of the level. So where we talk about testing, the MOH staff should take lead in that, sample correction, transportation. We'll see how this works out. And the systems in terms of data management should still stand and be led by MOH. All the lab systems should be headed by the Minister of Health leadership. And we've also had in some case scenarios where facilities close up completely, those that were being managed by some of the IPs, especially the drop-in centers, serving the key population groups within the HIV population, HIV cohort that we have in the facilities. We also account for those that are actually accessing services in the DICs. So when they get back for their refills in these drop-in centers, they found them closed. So what they had to do, they had to get back to the public facilities for their refills. And because of the uncertainties that have been made or we've noted, we decided actually to advise the facility staffs in those public health facilities that they should be registered as transfer-in patients, because in our registration processes, we've got two categories. We register someone for the first time, so we call it first-time registration on ART, or transfer-in patient registration at the facility. So these ones are moving from a different facility to your facility that have been on treatment already. So this is what we have actually not done, especially for the key population groups that have been accessing services in the drop-in centers. And we've also done what we call the training needs assessment, not to make sure we've got adequate staff, especially with the growing cohort and maturing cohort, that the services should be provided in an integrated manner with NCDs as well as the HIV. So this has been done. So targeting every platform that might be there when it comes to integration. Will it be partial? Will it be maybe a full integration? So this is what we're actually working with the site level staff to make sure how we go about it and making sure they get capacitated to have this done. So and also part of the needs assessment, we've also submitted to our authorities for possible recruitment and also decongesting the increased facility workload. We talked about the 6 MMDs, provision to those that are meeting the eligibility criteria so that they have longer spacing intervals in terms of accessing the facilities for their refill. Monitoring of sample transportation is actually not happening. Presently, we've only made a list to only facilities that have got capacity that maybe they can resume some of the services that we actually are on hold with the limited waiver that has been provided. So trying to align it to what we have as a contingency plan. Monitoring of sample transportation system and also reprioritization is still ongoing, depending on the country context, resource availability, the envelope that we have from all the pockets that we have. Presently, the available funding source now it's on a global fund that can support us with commodity procurement and also distribution and also consumption. So site level consumption as in ART, as well as the supplies for testing and then initiating them on treatment. So this is the current progress. Aside from that, the ongoing consultative meetings that we are doing and the leadership of the ministry within the interdepartments and weekly updates that we'll also be making together with the site level service provision. Like today, we're also having the same meeting that is happening around 4 with the directors of the districts in terms of how much progress we are making in unlocking some of the areas that looks for hazy. From here, I'll also hand over back to Chifundo to finalize with the 2 or 3 slides that are remaining.
Thank you. In conclusion, lessons have been learned. Yes, they have been learned in a tough way, in a quite a rigorous way, but lessons have been learned, tough lessons. So, like you have seen, we have had rigorous sequence of events to reach here, and this could not have been possible if we did not have political support. So, in conclusion, I would say that there is highest political endorsement to the country's strategic plans for HIV programs. And as of now, there is full integration of HIV systems into all our routine services. We continue to foster efforts in streamlining capacity building in an integrated approach. And also, we uphold high impact services that are sustainable, accessible, cost effective, and improve coverage. Thank you so much for your attention.
Thank you very much, Chifundo and Stanley. Fascinating and really a great way to deal with this challenging situation. And I note that it's also always said that luck favors those who prepare. And so it appears like Malawi, among other countries that we're yet to listen in from, was actually preparing for the eventual decline in funding around health services. And so luck probably is going to favor you a lot more than those who may not have been as prepared. Let me also note that sustainability, we have spoken sustainability from, I think, early 2000, PEPFAR 1, PEPFAR 2, PEPFAR 3, and all these other funding programs. But it looks like we were speaking sustainability within external funding instead of sustainability without external funding. And now we get to a situation where we have to actually look after our countrymen, continent men and women with very limited external funding. We like the approach of the goal model, a factual approach that really looks at which thematic technical areas are giving us the most returns and which ones do we deprioritize, let alone not deprioritizing in terms of taking them out entirely, but then they could be absorbed into other technical areas. We have also looked at prioritization of which technical areas are going to then be funded more aggressively, and then a structured approach to dealing with immediate actions. What do we do immediately? And then what are some of the things that we can do for long-term sustainability? So a very exciting presentation from Malawi. We will be getting additional presentations speaking to sustainability at the continental level, but for today it is speaking to experiences from Malawi. We have questions coming through in the chat. Please keep them coming and we'll be dealing with them quite in the next maybe 20 minutes extensively. We have questions that are coming, and I would want Stanley to start us off with one that came directly to me. And someone is asking, we are still speaking to terminologies that do not seem to be very sustainable, including a key population, priority population, ART clinic. Because running special clinics, we know that in the healthcare setting, there are special clinics that we are running, yes. Should HIV remain a special clinic? So some of these ART clinic, because in some countries, actually, they are non-existent. HIV care services is actually provided in the general OPD or in the general inpatient setting, depending on the condition of the recipient of care that we are receiving and in need of services. So quickly, the key priority population, key population, HIV clinic. Are we beginning to move away from this in Malawi so that our services are very integrated? And if you come as a gentleman, as a woman, or however you identify, all we're looking at is to care for you in an integrated way, not mindful about how you identify. So is that the approach that we're looking at in Malawi as well? That's the first comment that came in directly to me.
Right. So thank you so much for that observation. So as this parallel saving of the recipients of care in the drop-in centers for this population group was happening, like I mentioned before, we're looking at ahead of us, like maybe by 2030, that we may no longer have this external funding. Already, we had started preparing our public facilities in terms of capacity building to the service providers, that they can as well continue or coming to these public facilities to be accessing the HIV services, regardless of maybe the recognition. So for us, serving everyone as an individual, looking at the person-centered approach when it comes to service provision, but in an integrated manner, so that these kind of expensive models of service provision are actually run away for the sake of sustainability. So this is the approach basically that we are taking, and we had already started preparing our facilities, and it has started happening. And I mentioned also in this presentation that once the announcement of this budget cutoff had happened, they found these facilities closed. And so what did they do? They had to go to nearest public facilities that were still operational, and they've been received and registered and like in any other facility operational, normal facility operational. They're being saved like any other person in this facility. So this is what we are doing, integration. Thank you.
Thank you. Thank you very much, Stanley, there. And I will keep it with you just to deal with yet another comment, again, directly shared here. And it speaks to the testing network. You can do this, or you can delegate that to Chifundo to support with that. But your testing, how it is structured, some gentleman here needs to know how your current testing is structured. We see in some countries where we have centralized testing with very sophisticated equipment at central level, but running those equipment and the infrastructure that goes with them is waywardly quite expensive, including moving samples from remote locations to those centralized testing platforms or entities. So how is it happening in Malawi now, and what is the future looking like in your drive to have a more sustainable testing network for both HIV recipients of care, but also generally across the board for infectious and non-infectious diseases?
Thank you so much. That is a very good question. So as Malawi, I'll start with sample transportation. It is indeed true that our samples, we were chiefly relying on a courier, which is outsourced and being supported by CDC, that is R4H. So the mitigating measure that we are taking as a nation is that if they are to completely go, we would be using ambulances and also other means of transportation. And currently, we have engaged with our IP that as they are continuing to offer services, we are already integrating them with pairing them up with MOH staff so that they can be offering mentorship on how to run the transportation system. These are offices that we have earmarked to say that we are going to be having offices at facility level and also at central level. Those officers are going to be taking up the roles of the officers from courier companies to run the transportation system, and also the integration of sample collection that we have got. Not only R4H that has been collecting samples, we also have got other systems that have been collecting samples. So we intend to integrate our services, looking ahead that in the long run, we're going to, the Ministry of Health will fully take up the role of sample transportation.
Thank you, Chifundo. Exciting there. I have this question from Bobby, and I will add to another question that came through earlier. It's on research, and he's asking how the apparent funding cuts are going to affect some of the running studies, clinical trials or whichever studies that are running currently in Malawi, how they might be impacted. But adding to that, I am also asking, Stanley, do we see a situation where we have huge amount of data that we've collected over the last 20 years of care and treatment, and of course, prevention and diagnostic services that we've been providing to our clients, recipients of care. And we actually can use that to try and determine the first time we do a viral load. We currently, the time to first or initial viral load is 6 months. Then the subsequent ones are every 1 year if somebody is suppressed. The non-suppressed ones will go through intensive adherence counseling, and then they get to their next viral load testing. But looking at the practice that we were running currently and using the available data to probably come up with more care models that are less cost intense. Is that a consideration that Malawi is making, to look historically into the data and then see if you could probably do routine viral load in a more spaced manner and have it targeted to some population categories? Or do you still see that maybe that is not an area to go? So 2 questions in one. Your clinical trials that are running now, how much might they be impacted? Should they be funded by PEPFAR, or they are getting alternative funding sources? And then are you looking at using operational research based on the data that is available to us to try and probably come up with a more sustainable treatment model, care treatment models?
Thank you, Francis, for those 2 questions. I think I can start any on the list. So I'll start with the question that speaks to the viral load monitoring for HIV progression in our recipients of care. So indeed, we've made some policy changes over time in regards to how we would be monitoring the viral load. And this has been split between different population groups, like, for example, the pregnant women, lactating women, and also some children that their monitoring should be every 6 months. Whilst for the general population, those are outside these population groups I mentioned, should be annually. And to get to this, it was on a policy revision that we've had before, because previously we are doing it every 2 years, so viral load monitoring every 2 years. But then we shifted to this based on the emerging evidences that were there and also the funding support that was available to anchor it all. Now that we are into this situation, these are some of the issues that have to be made as decisions by the leadership with the available funding source within the country. It's a question that might not be answered right away now, that this is the way to go, but discussions that are still underway. I mentioned that we're having weekly consultative meetings with the leadership as well as the service delivery points in terms of how some of these policies will suffer. But basically, in a way that we need to contain the situation, we have to deprioritize some of the things and prioritize some of the things. So this, we haven't reached a decision yet in terms of how we're gonna tweak our policy not to suit the two-yearly monitoring of a viral load. In regards to the clinical trials, yes, I think that's obvious. If it's a study that was being supported by PEPFAR and not aligning to the interest of the US government, definitely if the cutoffs are made, continuation might not be there unless we get a different source to have them completed, looking at their impact also that they will bring, based on the results that we may yield, and also learning from maybe other regions, other countries where similar such studies have also been conducted. So yes, everything will be negatively affected if it was being supported by the US government, and decisions will be made by then. Thank you, Francis, and over.
Excellent, excellent. Thank you very much, Stanley. So one very quick one, it relates to, you probably already highlighted it, but it came through from Christopher, and Christopher is asking, if you're prioritizing human resource, I am modifying that. If you're prioritizing human resource as part of the core areas that should be supported with local funding, because it looks like you spoke very clearly about the other thematic areas that seem to avert transmission. But behind all those activities and processes, we have human beings that are supporting the delivery. But so, are we prioritizing human resource, those that were partner supported and are supposed to get out? And then also those that are government supported. It is interesting to note that somebody might be in the in the facility for over 10 years, for example, and they actually do not appreciate in detail the treatment regimen in the HIV clinic, the testing algorithm, because they are never part of that, and yet they're actually healthcare workers, and therefore they can't prescribe, they can't make requisition for treatment monitoring, just because they were never part of the program that was seen to be a standalone program. So what are we doing in terms of supporting a human resource, in terms of those that are partner supported and are getting out, but also those from the government side that should now be taking over if they were not part of the team that were providing care to our recipients of care for TB, malaria, or HIV?
Right. Thank you, Francis and Christopher, for that question. So basically, I think I also tackled part of this question in my slide presentation, that we have also requested for the needs, basically from the district leadership, where there are some gaps that where the program was being entirely run by the IP and is no longer there. We'll prioritize that in terms of the capacity building for those that might be redeployed to such facilities. And we've also lobbied MOH leadership for consideration in terms of the recruitment, that they should fill these gaps, whilst we have a working structure that is there, despite with the little knowledge that is there, but ongoing mentorship also supports that, because with capacity building can either be initial actually training of such service provision, or on-site maybe learning and then get supported by the mentorship activity in that regard. So capacity building shall happen, and we've already done the needs assessments, just a matter of putting up them together and going through the processes of accessing funds to have these trainings actually conducted. So I think this is what we are doing. Our modeling, the goals modeling that I talked about, mostly it was looking into the interventions that actually might have huge impact on on averting the new HIV cases. But what we are seeing it as a gap as a ministry entirely, it's basically the impact that the other programs might also suffer, because there's no way, the ministry, or I don't think there's any ministry that has employed anybody else just to be providing HIV services. These people are trained as health professionals. And within their service delivery, that's where they receive in-service trainings that, can today become experts when it comes to HIV service provision and also monitoring of the recipients of care whilst they're on treatment. So yes, the goals model has been done in terms of the interventions that can bring much more impact, but where we haven't done, it's the area of the negative impact that this redeployment or task shifting can have, because ministry doesn't just look at HIV program. The same people, human resource that we talk about in here, that are also responsible for other services like malaria, like TB, like pneumonia, every other cases or any program that exists in the facilities. Discussions are currently underway that modeling should also happen around this area, that as we are taking out these recipients of care from other service provision, getting here, what impact, what gap is it leaving from these other disease programs? So I may respond to that question that way. Thank you, and over.
Thank you. Thank you very much, Stanley. And we'll take one or two more quite briefly before we wind it up. Very exciting. Colleagues, keep the questions coming. For those that we may not be able to deal with, we will compile them and share those with the Malawi team. And then those will form part of the materials that we'll share with you. I have a question coming in from Davy, and Davy is asking because it looks like part of the sustainability approach you're using is to utilize the private sector. I know that even with funding, we've been utilizing the private sector, some of them the community pharmacies that were supporting us with dispensing medicines, and others were community drug distribution points located within private sector. And then they would get some reimbursement for the cost that they incur for providing those services. But specifically to Davy's question, he notes that the private sector is for profit. And so how might this affect clients who have been used to utilizing free services for everything from prevention, testing to care and treatment? How might it impact on their access to services, if you may want to preemptively say something in that regard?
Specifically for that question, it's only available for those people that have the capacity. It's not a mandatory. We are not forcing anybody, but we are only advertising the platforms that are available and also the attachments that are available to it. So like I mentioned before, we are still having the weekly consultative meetings with the broad stakeholders in our HIV programming. But currently, no, it's only for those that have got the capacity that they can access such services at that prescribed fee in the private sector. It may not be everyone, but those with capacity. So this is how we are trying to leverage on the private sector that is in existence. Aside from that, the integration component that we talked about, it's also trying to leverage on the issue of sustainability. So I may respond to that question that way. Thank you.
Thank you, and excellent. And we are still in the initial stages of this really walking the talk of sustainability, because I think the sustainability we've been speaking to for the last 10, 15 years or sustainability within available funding from external sources. So we have still a lot to learn, but thank you very much to the Malawi team for taking this first shot, and because you were initially already doing something preemptively to look at how you can make your programs more sustainable, because it is always known that in the long run, external funding will get down, and we have to take responsibility for the care and treatment of our own. So very, very well put here. For the first time, we'll be looking forward to more presentations from other countries and how they're doing this. And so as we come to the end, allow me just give the Malawi team an opportunity in 30 seconds to give us your closing remarks. And Stanley, you will decide whether you do it or Chifundo will do it.
Right. Thank you so much for having us as Team Malawi to share our experiences. They may not be the best experience because we are just 3 weeks into this contingency plan implementation, and things, they are changing depending on the information and communication that we are actually not receiving. And we are slowly also making adjustments. No, it hasn't come to a full stand state that this is the way to go. But within the 3 weeks, no, these are the decisions basically that the leadership in the Ministry of Health has actually made. And like we said before, moving forward, I think political will still stands, no, that supports every kind of the decisions and also service that would be offered within the country contexts, funding sources that are available in Malawi. So we are so thankful that you were there to listen to how we are progressing. being a learning platform, we are also eager to learn from how other countries have responded to this emergency. I know it has impacted so many countries. It's just Malawi that has shared their experiences and how much they are faring moving forward. But we are also looking forward to learning to how other countries are also doing. So thank you so much for hosting us. Thank you.
Thank you, Team Malawi. Excellent presentation, a very structured thought process in making sure that you can get back to your feet in terms of making sure that then care and treatment, prevention, care and treatment, diagnostic network, and the other support services, relay of results, the M&E functions can stabilize even with this turbulence that is around us. We look forward to hearing more from you, Team Malawi, because we know that in the next 3 or so months, a lot will have changed, and we will be looking forward to hearing from you, among other countries that will be hosting on this. And let me note that even when the external funding may seemingly get back in some form or format, the idea is that we should work towards making healthcare services provision, education, agriculture more sustainable with more of local funding or sustainable external funding. There are approaches that can actually help you get sustainable external funding. And so with those, we'll come to the end of this, and then we'll meet you in our next session. And so from us, ASLM and the team in the background, do have the best of your afternoon, evening, or morning, depending on where you're joining us from.
Thank you. Bye-bye.
Thank you. Bye.